Kia ora, and I'd also like to add to the welcome to all of you, and it's fantastic to see such a great and diverse audience. It's also fantastic, I think, hearing the historical context in this area, because, as we know, Ben mentioned some of those enduring themes of housing, crowding, and concerns about infectious disease from a century ago, and I think it's fascinating the way these themes keep coming back. So, as Richard has mentioned, I'm going to be talking about, shifting the emphasis a little bit to look at the health effects of housing. And I'm very pleased to have my co-author this work, Jane Zhang, in the audience, who's done a huge amount of data analysis for this. So some of the areas I want to talk about are really some background to why we've got concerned about social housing. The method that we've used here, this social housing outcomes worth study, which we think is the largest cohort study that's been done so far, looking at the health effects of housing. And then some of the key findings that we think are quite relevant to the discussion here today. The fact that this is obviously a vulnerable population. They have very high need for healthcare. They're exposed to a lot of hazards in the private rental market, and there's a potential for social housing to reduce those hazards, particularly the area of crowding. We see improvements in health when people move from being applicants to tenants. And also I'll talk about some of the results from the Healthy Housing Program, which we think was a brilliant initiative carried out in Auckland over the last few years. So I got started in public health in 1991, and my first job was to describe the epidemiology of meningococcal disease. And I said, it's gone up about 25%, that's an epidemic. I thought it's not going to go any higher. And of course that was the beginning of a very prolonged Group B meningococcal disease epidemic in New Zealand. And the reason I mention this is that this is a very unusual event. But even more unusual was something that's almost slightly historic now, was the serogroup A epidemic, mainly in Auckland in the 1980s. And this is the thing that really astounded people, because this has only ever been seen before in sub-Saharan Africa, this particular type of meningococcal disease. So really New Zealand's had a very sorry history in terms of unexpected infectious disease events over the last 30 years. And recently, as Richard said, I've done a lot of work describing the epidemiology of disease, but of course after a while you get sick of describing it and you want to actually do something about it. And I think that's really the motivation for a lot of people to think about the upstream factors like housing conditions. But recently, earlier this year, we published in The Lancet re-analysis of the total burden of infectious disease in New Zealand. And this really amazed us, and I think it also surprised The Lancet, based on their editorials, that a developed country like New Zealand, which is seen overseas often as a form of paradise, still has these terribly high rates of infectious disease. And the fact they've risen by 50% over the last 20 years. And much faster, in fact, than the chronic diseases that we increasingly need to worry about. So in many ways, New Zealand is now, to some extent, two societies. We have a society, like probably many of us in the room here, who have really benefited from the progress of improved living conditions and so on. And we have another group in New Zealand who are still exposed to really appalling environmental conditions. And part of that is related to housing availability and crowding. If we look at some of the drivers, and I think we'll probably come back to this, is you only have to look at the data on the housing situation to see some relationships. If we look at, just going back here, really the increase in disease burden was very much in the 1990s. Something happened in New Zealand, and we know that there was a change in views about the role of the state and income distribution. And that was reflected in this rise in the proportion of the population who were exposed to low affordability. And it's a somewhat arbitrary definition, but this is from the Ministry of Social Development Social Report. And I think they do a great job of monitoring the health of New Zealanders from a number of perspectives. But certainly their work has shown that the portion of New Zealanders who are living in unaffordable conditions has increased greatly, and that was again very much in the 1990s. And we saw this, and I've got a lot of material on crowding, but we saw this manifest in a rise in crowding for some groups, particularly children in Maori and Pacific families. So this is really the driver for this work we've been doing with Housing New Zealand, looking at the health of housing applicants and tenants. And that's this social housing outcomes worth study. And Housing New Zealand supplies housing for around 5% of the population, about 200,000 people. And as we've heard, it's considered an important safety net with benefits for individuals, families and communities. But in fact, the health impact of social housing has been very poorly measured. There's virtually no published work on this topic. And so we set up this study in 2003. And this study really aims to describe the characteristics of Housing New Zealand tenants and applicants and compare them with other New Zealanders. And particularly, it looks to investigate the relationship between housing conditions, particularly exposure to household crowding, and a range of health outcomes. And of course, on the positive side, we also want to see what the effect is of interventions and programs to improve the health of tenants and applicants. So this is what we call a record linkage study, and that we start with information collected by Housing New Zealand for administrative purposes. And when someone applies for social housing, of course, there's a very well-established needs assessment process for prioritising those in greatest need for social housing. And so this process collects a lot of data about the person's circumstances, crowding levels. And also, about 95% of current tenants fill out an income-related rent form every year, and this is where they report income and so on, and this is the justification for continuing to receive income-related rent. So those data are transferred to the Ministry of Health, where the identifiers are removed, and then they're passed to us, and we then link this essentially anonymous data on the Housing New Zealand population with health data. And New Zealand is fantastic in having this unique National Health Index number. It means we can link people, all of us can be linked, we all have an NHI, can be linked to our hospitalisation and mortality and other data. So we can look at the health of people, of applicants and tenants. So one of the first things, it's a dynamic system. So you have people moving from the New Zealand population to being on the waiting list, becoming tenants, and then moving back into the New Zealand population. And here, obviously, there are much smaller numbers. There's around 70,000 households as tenants, about 10,000 on the waiting list, and that's probably going to change, or is changing at the moment. And you have people moving in and being placed on the waiting list, exiting the waiting list if they don't get a house or they move into the private sector again, and some are housed every year, and some also exit from these tenancies. So we track all of these people, or Jane Zhang in particular tracks all these people for this study. So just in terms of the main findings, the first, and I guess the most obvious thing about the population is that they are really quite different from the New Zealand population as a whole, and this is 2006 census data here, so things may have changed a little bit, but the distinguishing features are this is a very youthful population. So the median age for tenants is 20, which means that half of the tenants are under 20. So a lot of children in these houses compared with the New Zealand median of 35, and applicants are somewhat similar. Another distinguishing feature is a very high proportion of Māori and Pacific people in this housing, a high proportion of single-parent households, very low income, and a high proportion receipt of government benefits of various sort, income-related benefits or means-tested benefits. So looking at the second broad finding is when we link applicants and tenants to their hospitalisation records, this indicates a very high rate of serious disease, because these are people admitted overnight to a hospital with acute illness. And in New Zealand as a whole, about 9% of the population is admitted acutely every year, but it's about twice that for housing applicants and tenants, so very high rates of significant disease. And even if we adjust for the age and ethnic mix of applicants and tenants, we still find that their risk for applicants is two-thirds higher than New Zealanders and 53% higher for tenants. And this is just showing that relationship over time. It's a very consistent relationship. And we can see, in fact, this extra vulnerability. This is hospitalisation rates on the vertical axis here, and this is distinguishing applicants and tenants with everyone else in New Zealand who's not in those groups. And you can see for young children, the risk is, and slightly older children, the risk is high, and it continues really throughout life into middle and older age. So a third question we've been able to look at with this study is this question of exposure to one risk factor for disease, and that's household crowding. And we're using a standard measure, the Canadian National Occupancy Standard, which just measures or compares the number of people in a house with the number of bedrooms. And generally, a deficit of one bedroom is considered crowded, and 2 or more bedrooms is considered severe household crowding. This is the Statistics New Zealand approach. And we can see that severe household crowding is quite a rare exposure in New Zealand, about 3.5% of the population. It is relatively high still in tenants, around 15%, but in those who are applying for housing, so they're on the waiting list, it's around 25% of households or applicants who are exposed to severe crowding. And as you can see up here, these relationships are fairly consistent over time. And here you can see that for applicants, around 50% are exposed to some level of household crowding. So certainly it appears that this move from being an applicant, in other words, in the private rental market, to becoming a tenant, is linked to a marked decline in exposure to household crowding. But clearly we could do better with our Housing New Zealand population, and this is partly related to the available mix of Housing New Zealand properties in relation to the sizes of the households that are living there. So a fourth area that we've been looking at with this study is what happens to you when you move from being a housing applicant to being a tenant. And this again is showing this measure we're using quite a bit, the age standardised hospitalisation rates. And you can see that this is the rate of hospitalisation in people who are about to move into a house, so they're on the waiting list. In other words, they're still living in the private rental sector. And after they move into Housing New Zealand housing, their risk of hospitalisation declines, and it continues to decline over a number of years as they stay as a tenant. And these are highly significant drops in your risk of being hospitalised. And of course, with all of this work, hospitalisation is only one measure of how people are getting on. We've got a lot of other measures. It's just that we can measure this now quite precisely with this study. And again, these effects apply really across the whole age span in terms of, again, this is your risk of hospitalisation before, when you're still living in the private sector, private rental market, and then moving into social housing. We see these very marked declines in hospitalisation rates for most groups. So the fifth area, which I think has been the most exciting, has been, well, what happens if you actually take the social housing population and you actually really try and improve their health with very active measures. And I think a remarkable development was the Housing New Zealand Healthy Housing Program, which started life in the early 2000s with a pilot in Auckland. And this was the first one that, as we know, Prime Ministers have a connection with social housing. They're brought up in it, or they like to stand in front of it and be photographed. And again, this was a fantastic initiative, and it started in Auckland, and it was rolled out in 2003. And I don't know of many better examples of joined-up government. And basically, this model involved identifying communities, areas with particularly high rates of disease and hospitalisation, going to those communities and going to all the social houses there with a joint assessment, which had someone from Housing New Zealand, a tenancy manager who was going to look at housing conditions, and someone from the DHB who was going to look at the health needs of the population there, and then work out an appropriate set of interventions, which involved these housing interventions: ventilation, insulation, heating, crowding reduction. And the health side was really particularly looking at how well connected people were with primary care and other social services. So what effect did this have? Well, we have done a study also with input from Michael Keel and others comparing the tenants here with the people who were social housing tenants who weren't in the areas that got the intervention. So we have an intervention group and a control group in Auckland and Northland. And we found that, and this is 2 evaluations have looked at this now, and both found a very positive effect for children. And this is really for children under 20 who have a very high rates of hospitalisation, particularly those under 5. We found almost a 30% reduction in hospitalisation rates. And really, there's nothing else we know that's as effective at keeping children out of hospital. And of course, if this was a vaccine, we'd bottle it and sell it. I mean, it was quite remarkable. And the crowding reduction interventions were even more effective, particularly for reducing infectious diseases. So there was a very strong form of what we call biological plausibility with this. So I think we can draw some conclusions from this, that the social housing population is amongst our most vulnerable. You have to be in the lowest income 5% of the population to even get on the waiting list. And in some places, you may not still get social housing. It does depend a bit on local supply. We can now look very precisely at your risk of hospitalisation and injury, and it is markedly higher in applicants and tenants. So we've got good objective evidence about that. Shifting people into social housing and greater duration in social housing is associated with better health. In other words, lower risk of injury and hospitalisation. Although this is quite a complex relationship because of the way people move in and out of housing, and we need to do more work on that. But I think the most positive finding we've discovered so far is that working with this group in an organised way, using the different levers of society through housing and health, really can achieve fantastic and measurable outcomes. So the implications we draw from this is social housing continues to be a very valuable safety net, potentially increasing the supply of social housing, and I guess we're focusing what Ben described as the direct form of assistance rather than the indirect form through, say, the accommodation supplement. It does, based on these data, there is potential to improve health and well-being in New Zealand and possibly reduce healthcare costs overall. And I think, and this is what I think is most exciting, is that social housing does provide a fantastic opportunity with very active programs to really improve health in very measurable ways. And as usual, this has got a lot of collaboration, a lot of support. Philippa and others who have been collaborating on this project for the best part of a decade, and also huge support from the Health Research Council. And of course, we couldn't do it without Housing New Zealand, who've been a brilliant partner throughout this work, and we really hope that will continue into the future. Thanks.